My name is Ada Skiles, and I'm the Associate Director of Chapin Hall at the University of Chicago. On behalf of Chapin Hall and the Urban Institute, I would like to welcome you to our final program for this season of our Thursday's Child Public Policy Forum. We would like to thank those of you who are here in person and our listening audience for taking the time to be with us today. Today's program is entitled Health, Education, and Child Welfare, Measuring Outcomes Across Systems. Moderating our panel of experts is Chapin Hall's Executive Director, Matt Stagner. Again, thank you for joining us today and being interested in our program. Matt will now introduce the panel.
Thank you, Ada, and I'd like to add my welcome to those of you in the room, as well as I understand over 1,000 people who are listening to the web broadcast of this event. So we've obviously generated some interest out there, and I think we have a great panel to start us on a conversation. I'd like to introduce the panel, and then as those of you familiar with the Thursday Child format know, each of them will speak for a few minutes, 6 to 8 minutes, putting out a perspective. Then we'll have a brief conversation among the panel and open it up both to questions from the live audience as well as the web audience. We also took in some questions via email in advance of the session. So generally we have lots of questions. We can only get to a few of them, but one of the nice things about the web setup is those questions can then be answered over the coming weeks as well. So let me quickly introduce our panel and get started. Our first speaker will be Fred Wolshin. Fred's a research fellow at Chapin Hall and is the director of the Center for State Foster Care and Adoption Data, which is a joint venture of Chapin Hall and the American Public Human Services Association. Our second speaker will be Jane Hanaway. Jane is a senior fellow and the founding director of the Education Policy Center at the Urban Institute in Washington, D.C. Our third speaker from the health perspective is Alina Chen, who is a health services researcher at Children's Hospital in Boston. And then finally, we will have a funder perspective from the Chicago Community Trust. We're very pleased to have Jim Lewis, who is a senior program officer at the Trust. So with that, I'm going to turn it over to Fred to get us started. Again, each of our 4 panelists will make some comments. I will then possibly generate a couple of questions amongst them, and we'll turn it over for the last section for questions from the audience. So Fred?
Good morning. Thank you, Matt. Welcome to everyone as well, and to those of you who are listening in online. Very glad to have you here with us this morning. It's hard to imagine talking about a topic as complicated as this in 6 to 8 minutes, so I will try to boil down to what I think are the salient issues, and I think they'll emerge over the course of the morning in the conversation that you'll be hearing from our colleagues joining us. I think the first thing to realize in the context of performance measurement, monitoring, whatever side of the activity you're talking about, is that we're really interested in the issue of variation. Kids come through the child welfare system, the schools, the healthcare system, and they have different experiences. And we want to understand why they have different experiences because from a clinical or a service perspective, we'd like similarly situated children to have roughly the same experience. And it would be particularly desirable if that notion of the same experience was constructed around the link between that experience and the outcomes that system is intended to provide. So the real issue here is variation and understanding it in its from the perspective of where does it come from. And in the particular case of performance variation, what we're really interested in is the performance of the organization providing the service. We want to know to what extent do the outcomes vary because of the children, in the case of the child welfare system, because the children bring to this system different characteristics, different family backgrounds from different families, from different communities, and to what extent does that variation play a part in what we would then aggregate into an agency performance or a public agency performance. So we really need to be clear from a levels of analysis perspective, where is the variation coming from? the agency, the state, the jurisdiction, and understanding how that affects the outcomes. When you look at it from a levels of analysis perspective, then you realize that there's lots of things that can influence the performance in addition to just the practice model of a particular organization. There's public investment that varies tremendously, that isn't the specific responsibility of a particular agency. So it's the fact that agencies are nested within states or counties within states, depending upon how you aggregate the data to try and understand that variation. But it's critical that we do so. I raise this point in the context of the child welfare system because from the federal perspective, and that's the primary driver of this interest in performance management in the child welfare system, is emanating from the federal government. And by and large, the federal perspective, as it stands now, and it's always evolving, and importantly so, but from the federal perspective, all performance variation in the child welfare system across the United States is attributed to the organization, in this particular case, the state. There is no case mix variation. They're not accounting for differences in the children served. So, for example, some states serve many more babies in their foster care system than other states do. Those babies have very different experiences than, say, teenagers. Yet those differences are not accounted for in the way states are graded within the context of the federal system. So that kind of case mix variation as a source of variation that would account for differences in performance has to be taken into account, and the current standard of practice right now from the federal perspective is that it's not. When you do take that into account, when we do that kind of analysis of our own with respect to states and localities, we find significant shifts in the relative performance of agencies once you account for the fact that they are serving different populations of kids. Another problem in the realm of performance management, particularly again in the context of the child welfare system, has to do with whether one should apply standards or baselines. The issue of standards goes to standard practice, that is what's usual, and then performance standards. How often do you perform what's usual? And again, here the idea of usual is best when it's linked directly to outcomes. You should do those things which have a link to outcome. You should stop doing those things that don't have a link to outcome. And the question of standard of performance, how well do you follow the protocol? What's your fidelity? That's an important issue around quality and process of care. The question is, do you apply standards for outcomes, or would you be better off using a baseline as a way to manage the variation? My own view on this is that standards are appropriate for the process and quality of care. You have a quality standard, you have an expectation that protocols will be followed, and you either achieve that standard or you don't. With regard to outcomes, that gets to be a much dicier proposition because we are inferring that we know ahead of time what the outcome should be for a particular child. And that generally is uninformed because you don't yet know the children you're going to serve over the course of the year. So that's, in a sense, clinically uninformed expectation. Plus, on the outcome side, there's lots of random things that can happen that break the link between what you do and the outcome that has nothing to do with the fault of the protocol that you're following. It's just that there's a tremendous amount of random, unexplained variation that occurs in relationship to outcomes. So I think we have to distinguish when it's appropriate to use baselines, when it's appropriate to use standards, and my preference would be to use baselines for standards as the way to measure change and variation in the performance of child welfare system as it relates to the issue of outcomes. Then I think the last thing that I would urge the field to take a close look at is this issue of change over time. The performance improvement is, in effect, trying to detect change in what happens over time. And when you start to think about issues like variation that's due to the population changes over time, the case mix of kids being served by the child welfare system in particular from year to year, it's fairly stable, but there's enough variation in that population over time that alone could account for change in performance. So I think that the science here has advanced, particularly for the child welfare system. The science has advanced, but the theory of performance monitoring in the context of our particular slice of the systems that are represented here today, we are behind the theory in terms of how to apply measurement of performance in the context of the child welfare system. Interestingly enough, we have the data and have had the data for quite some time, and it's a question of getting the theory to catch up with the data and applying it in a more robust fashion than we have to date. So thank you.
Thank you, Fred. One of the things we noticed in talking about this panel is we have a bit of what I call an eat, shoots, and leaves problem. In the title around, are we talking about measuring outcomes across systems? Are we looking across systems at how we measure outcomes, or are we talking a little bit about both? And the questions that came in prior to the panel helped elucidate that problem. So what we're doing is talking first about within each of these sectors, what are the challenges to performance measurement? Jim will be talking about looking across the sectors he has to be concerned with in funding. And then in the conversation, we'll start to get at some of these issues around thinking about how these sectors relate to one another. So we'll turn now to the education system and to Jane.
Thanks, Matt. I get very excited when I talk about education and data and measurement. So and they're holding me to 6 minutes. And if I go too far, Matt, you know, the good thing is Matt's sitting right here next to me. You're just going to have to jab me, and I'll
disconnect you.
Right, disconnect me. So let me try to talk fast, because I think education has gone through a real revolution in terms of data and data use. And there's good, bad, and ugly about it, and I think lots that can be learned from it. Let me give you a few, first of all, sort of system-level facts. So this is education in the country as a whole. Not much more than half of minority kids graduate from high school in the U.S. By the 12th grade, those minority kids who are still in school are, on average, 4 grade levels behind white kids. Only 15% of minority kids get a BA 9 years after 9th grade, so this would be taking into account the dropouts. So we got problems. Now, we've got big problems, and when you compare what's going on in the U.S. to our economic competitors, you can see how we're falling further and further behind. So system-level performance measures say big trouble. They don't give us a clue as how we should go about correcting it. Then along comes No Child Left Behind, the most far-reaching ever policy initiative of the federal government. I think one of the most important things that's come out of No Child Left Behind and out of its accountability policies is the creation of data systems across states, fairly sophisticated data systems that track individual student performance. Right now, nearly every state, I think it's 49 of the 50 states in the country, have data systems in place with a unique student identifier at the state level so that you can track students over time. Never before could we do this. We always looked at things cross-sectionally. How are the 4th graders performing? How are the 5th graders performing? But we never could track the progress of individual kids. Now, in almost every state, we can do that. The stimulus package has the federal government has been investing heavily in these data systems. Stimulus package is putting more money into it. In addition, in about nearly half the states now, we can link teachers with students. So we not only can look at students over time, but we know who their teachers were at each grade level, at each point in time. Gives us a lot of information. Florida is probably the most developed system. We can track kids there from pre-K through elementary school, through middle school, through secondary school, through college and university, even when they leave the state, and then we can track them into employment. So there is a fantastic data system that is operating there and that is emerging in other places. Okay, let me tell you some of the good things and some of the bad things about these data systems and some of the findings that have come out that have giving us important insight into how to attack those system-level performance measures that I mentioned earlier. Let me tell you the good things. Number one, with these longitudinal data systems, we can calculate gains. So this is education, And what we can calculate is gains in academic achievement of kids. Never before could we do this. We can also estimate teacher effects. So we can estimate the effects of teachers with particular characteristics and their contribution to those gains. Thirdly, we can adjust for risk, which I think is one of the issues that Fred brought up, that because we have these data systems on individual kids going back a number of years in time, if we have at least 3 years of data with some fairly sophisticated statistical techniques, we can basically take most of the characteristics, the inherent characteristics of those kids into account when we're calculating gain. So these are risk-adjusted gains. Fourthly, it's very easy to aggregate the data. So we've got the data at the individual kids. Okay, I can aggregate it to the classroom level. Okay, I can aggregate it to the school level. Okay, I can aggregate it to the state level. It's very, the computer does that like that. Bad things. These are the complaints that you get about estimating performance measures on the basis of these data. And they should be taken seriously. One is they tend to narrow the objectives of what's going on. So you hear a lot of complaints about narrowing of the curriculum. You hear a lot of complaints about certain subjects being favored over other subjects because those are the subjects that are getting tested. You hear a lot of talk, and these are empirically validated too, a lot of talk about the particular skills that are being used on the test as having an advantage in terms of teacher effort than higher order skills maybe depending on the state tests, or creativity or love of literature, those other things that you want schools to engender in kids. The argument is that they're getting the short shrift given that they're not tested. In addition, the outcome measures that we use are test scores. Test scores have built into them measurement error. And the reason they have built into the measurement error is because they simply sample. They're sampling efforts. They sample those things that are taught in the classroom. And so they're constructed by psychometricians, and they do a terrific job in doing this, but all you're ever getting, you're never getting a test that's telling you everything the kid has learned. You're only getting a test that samples what the kid has learned, and you make inferences based on that, and like any other sampling effort, there's measurement error built into that. So those are sort of the good things and the bad things associated with these outcome measures. Let me give you some feel for the sorts of findings that we're getting. And this goes back again to my first comments on the system level problems that we have, because they're huge. And I might add that for many years, even a couple of decades, many people argued that schools could not affect student performance, that it was basically driven by the background characteristics of the kids. Some of that research came out of the University of Chicago, but that was sort of the belief among many people, that when you had poor minority kids, you did the best you could, but what are you going to do about those families? They're the ones that are doing it, the schools, what can we do? Okay, so then we have these new data now, where we really can get inside and figure out what's going on. We can calculate gain. We can look at who's making gain and who's not making gain. We can look at the conditions under which that gain is being made. We know a whole lot of stuff about the individual characteristics of the kids. Lo and behold, some teachers are just knocking this achievement stuff out of the ballpark. And these are teachers who are in high poverty schools as well as teachers who are in low poverty schools. In fact, the variation in teacher effectiveness within school is at least as large as the variation in teacher effectiveness across schools. So you go into the worst schools or what you might consider to be the worst schools in Chicago, and there are stars in there who are doing terrific jobs with kids that, for many years were just written off. So we know that teachers are very important. We know they can do it, and we know some of them are doing it. And the differences are big. So the best teachers, get this, the best teachers are getting, on average, about a whole year more growth out of their kids than the weak teachers are. So you can imagine what we can do in terms of reducing the achievement gap if we can have a situation where kids that are coming from these disadvantaged backgrounds are getting the best teachers for a number of years in a row. You can also imagine what happens, here's Matt, to some of these kids if they get a bad teacher and they only make a half a year's gain. You get one of those teachers a couple years in a row and write it off. Okay, so one thing is teachers can make a big, big difference, number one. We also said, okay, what is it about teachers that are making a difference? It's not our standard indicators of quality. It's not associated with teacher certification. It's not associated with years of experience beyond the first couple of years. It's not associated with master's degrees. And those are all the things that we pay teachers more for. So if you look at the investment patterns in education, we're paying more for characteristics and factors that are not strongly associated with achievement. I'm going to stop here, but I think you can see where these findings are starting to lead the education policy talk in the U.S., and maybe we can follow up with some of that later.
Good. I'm sure we will come back to that. So thanks, Jane. Our third perspective is the health perspective, and I'll turn to Alina.
Good morning. Am I on? Okay. I'm really happy to be back in Chicago because this is my hometown, and I was at the University of Chicago for all of my training and my junior faculty time. So I've only been gone for 9 months. So I really am happy. Yeah, thank you. So I'm a pediatrician. I don't know how many healthcare providers we have in the audience. When I was looking at the audience list, it didn't seem like there were very many. So I'm going to provide some broad strokes of healthcare because really in health, we have as healthcare providers confined ourselves to a service delivery model, and we wonder and we hope to address issues of health, but that's just considered a much broader concept, and we haven't necessarily taken that on. So that is my first caveat. Healthcare has all of the same data quality, methodological issues that have been outlined for welfare and for education. And in fact, it sounds like a little bit weaker on the data front because we cannot track children over time. We do not link them necessarily with individual providers, which is what they're able to do in education. So actually the data for welfare and education sound better than healthcare. I'm salivating. So my first point is that I'm sticking to the construct of healthcare, not health. And I apologize that that's the way it is, but we would like to change that. The second is that we have inherited a healthcare system that is largely dictated by what the adults need. And this goes from what we decide to treat. There's a disease model in healthcare. How we pay for it, we generally pay for quantity, how many times somebody walks in the door, or whether or not they're on our panel as a provider, rather than the quality of the healthcare we deliver. And I just want to provide some examples of this. So the adult system has been set up over time to be addressing acute life-threatening illness. There's about 300 million adults, there's 60 million children. So you can see how when you're a minority in the system, it may not quite work for you. We have about 300 doctors per 100,000 adults. We have about 100 pediatricians for every 100,000 children. There are 5,000 hospitals, mainly for adults. Half of them treat a small number of children each year. And then the ones that are directly serving children, there's 200. So you can see how when we take care of kids in the healthcare system, they're a minority voice, and the services aren't quite oriented towards them. The healthcare services children need, as opposed to acute life-threatening illnesses, is prevention, screening, optimizing health, getting to kindergarten ready to learn, finishing high school, even if you have a chronic illness, not falling behind. So the system has inherited a disease model, and its entire structure is oriented towards that model as opposed to what we would probably want if we were just thinking about kids and what kids need. So when we ask about how healthcare is doing for children, I just want folks to keep in mind that that is kind of like asking how well a screwdriver does a hammer's job. Okay, so within that context, we do have performance measurement traditions in healthcare. Again, it mirrors that of what we're doing for adults, but it's kind of like a funhouse mirror because all of the systems are set up around making sure that people don't die, adults don't die. So there's a lot of performance measurement, for example, around coronary artery bypass grafts and whether or not a patient dies. So for a kid outcome, kids don't die that often. We do look at infant mortality, but certainly that's not something you can relate directly to an individual physician or a hospital, because infant mortality, we think there are a lot of other inputs like housing, education, that create a situation in which a child might die in their first year of life or not. The adult folks have done a very good job with adapting the acute disease-oriented system to one that is trying to serve chronic illnesses. For example, diabetes, there is a lot of evidence around the quality of care delivered for diabetes improving, whether or not a person goes blind, whether or not they need a kidney transplant. We don't quite have that for children. But again, it's another place where we're trying to adopt sort of the way we've been thinking about the adult system for children. And I think the counterpoint condition for diabetes in kids would be asthma. And so performance measurements around asthma are not necessarily, wow, did the asthmatic go to school every single day and function just as well as a child without asthma and not need to take any breaks. They are whether or not when they came into the hospital, a point which you don't really want to get to, did they get certain kinds of medications. So it's the orientation is more around the way we deliver services, not around what we want for children as outcomes. So my final point is when we think about measurement, I think we want to think about in health and healthcare. We want to think about whether or not we're addressing health versus healthcare. And then we want to also think about whether or not we're using inwardly focused measures like, did I give a steroid for the kid with asthma? Or do we want to focus on measures that can be used across systems? So certainly education would care whether or not the child is showing up to school each day and fully functional on their ADHD medications, on their antidepressants, or things that really do affect a good proportion of children. And then I think the final thing that all of the panelists probably would agree with is that we want to think about whether or not the measures reflect the system you're in right now versus the system that you want for the future for kids. And I know that we all get paid according to the system we have, but we kind of need to reach across borders and think bigger in order to get the system we want using performance measurements. Thank you.
Thank you, Alina. And now if you think these three folks have a hard time within their own areas, we're going to turn to somebody whose day-to-day has to look across these areas and others and figure some of this stuff out. So I turn to Jim.
Well, I'm with the foundation, and I buy stuff. And I like to shop, and I like to comparison shop. And I often liken what I have to do, unfortunately, to if any of you went out to buy a car and found that that car had no odometer in it. That means not only do you not know whether it's been driven before or how far, but you're not going to be able to calculate the efficiency of its gas mileage in the future either. And you find that most of the cars don't have odometers. So you're going to buy the red one. Or I always wanted a Corvette. And that's unfortunately where I think a lot of the philanthropic world is a lot of the time. And I try as little as possible to think of myself as a philanthropist, and because that's really not my background at all, if you look at the bio, but think of myself much more as a purchasing agent. I have money. The trust charge is to hold that money and spend it in trust for people who want to improve the well-being of people in Chicago. So I'm trying to buy as much of the well-being as I can with the dollars that we have. And so to do that, we need data. And there's plenty that we could talk about around that. I think the most challenging issue is the one Matt sort of led me into, which is that spending that money in its best way across a variety of different sort of human services functions requires not only picking the best school among many or the best healthcare provider among many, but also deciding whether the investment on the school was more efficient than the investment on the healthcare. You have to not only pick the best options within a particular sector, but you also have to pick the best sector, and that's where that one construction of the word across fits in our subject for today. But you need to pick the sector where you're going to do the most good as well. And as advanced or limited as the work is in any individual field, the thinking and the actual process and ways of analyzing data across sectors are even more limited. The most traditional way to do it is through benefit cost analysis. And there's a gigantic literature on that. And the basic assumption you have to be able to make to do a cost-benefit analysis is that you have to monetize the outcome in some way. That can be framed in terms of money, some kind of money or value that goes to an individual that's served. It can be framed as expenses that are avoided by government, kids who didn't grow up to go to prison, kids who didn't grow up to use welfare, different sorts of savings of that kind. But it requires ultimately that you value what you have done in terms of something that can be valued with money. And I think there's an awful lot you can convert into that metric. There's a group called the Robin Hood Foundation in New York City that has taken some first steps toward trying to monetize all of the outcomes they do. They've simplified it in that their mission exclusively is the reduction of poverty. So the logical leap there is not very far to be able to measure all those outcomes in some kind of financial terms. But a lot of the things we've been talking about even thus far this morning are not purely about the financial monetary value of a thing. So it charges us with finding some other way to equate outcomes across systems that aren't necessarily about dollars. Education, there's huge literature in labor economics about the returns to education and such, which easily convert to money and would leave you with the impression that the sole purpose of schooling is in fact to help people make money or avoid costing government. But in fact, any of us who have kids know that there's a whole lot more benefit to schooling than just the job they're going to get. Healthcare, obviously, is not just about avoiding costs in late stages of life or avoiding costly medical care. It's about quality of life for those who aren't at risk of death. For them, I think the outcome's pretty immediate. But even that isn't purely a cost issue. And certainly child welfare, I think that's an issue where virtually none of it fundamentally is about cost avoidance. Really, it's about the quality of life of that child. And the challenge in doing that, doing the right kind of analysis on that to find ways to equate across these sectors, I think has been extremely daunting. Again, there's lots of work in the field of labor economics and the field of cost-benefit analysis that find ways to equate things once you've monetized them. but there's really very little, almost, and I think I might even be able to go out there and say none, that really effectively, metrically driven has found a way to measure outcomes across those things that don't monetize so easily. And one of my sort of personal areas of work that I want to do in coming years, in fact, is to try to explore ways to do that. But I think it's going to be very hard because I don't think anyone has done it well yet. Looking at some of the data questions that I think about across some of the different child-oriented fields in the field of education, I think of the areas, it is the area that I think the best data is in at this point of the child areas, and where it's been integrated the furthest in all sorts of different ways. I would say from my seat, the most challenging question there is that the outcomes for the child seem to come from three different areas. One is what happens in the school. A second is what happens in the neighborhood or the community. A third is what happens in the child's family. And studies have gone some distance in trying to disaggregate those. But the problem, there's endogeneity problems with neighborhood and school quality in particular, in that they are endogenous to one another, it turns out. Property values are related to quality of schools. The quality of schools related to the taxes that are thrown off by people that live within a catchment area. So that it's very hard to untangle those two factors, and obviously family isn't easy either. So I don't think the definitive work has been done yet on unentangling those three. But as a funder, I want to know where our dollars need to be most effectively put. Is the greatest amount of variation taking place in the school? Is it really that you ought to focus on solving the family problems and the schools would take care of themselves? How should you think about it? I think in the area of child welfare, we need to expand what the outcomes variables are. It's not just a successful placement, and it's not just getting through the placement safely. And as we look at different providers, the individual delegate agencies of state government that do most of that work, how do we want to judge them? Is it just on the placements, or perhaps do we look to them to really be held accountable at some level for the quality of life of the child within the placement? Should they be thinking about how that child's going to fare in school, the quality of the neighborhood, and things of that nature? So I think the challenge there is to expand the vision of what we consider outcomes in that field. In the areas of child care, early childhood, and in out-of-school programs, there's all sorts of evaluation studies that have been done of all sorts of varying quality, but the fact remains in both fields, virtually anyone can call themselves a provider. And there are, I don't think in either field there's really a standard. The standardized tests in education I think way have been a positive, actually, because they have whatever their failings as a metric and for various aspects of validity do provide something that's comparable across different settings. But there's almost nothing that's applied universally. Well, there is nothing that's applied universally across child care programs or pre-K programs. They're certainly good instruments, but for resource reasons, for understanding reasons, for political accountability reasons, they're not applied uniformly. And so trying to make judgments about efficiency and effectiveness and where our dollar is best spent, very hard to do across the systems because there aren't uniform data sets.
Great. Thanks, Jim. I'm going to take the prerogative of the moderator and ask a couple of questions, then turn to a couple of questions that have come in via email through the transmitter in my head or handed to me by someone else. And then we'll turn to the live audience. The first thing that came to my mind from each of our first three panelists was you hinted at how money and financing of the systems relate to the performance measurement issues, but we didn't really specifically say something about that. I think Alina maybe said the most about it, but I wonder, I guess the challenge is to think about how much does the way we now fund these systems drive performance, or to flip it around, how could a better performance measurement system change the way that we finance? And Alina, do you have more to say on that?
Well, I could just go into a little bit more depth of the things I hinted at. So, let me put this. I think that right now, the payers, anyone who's shelling out money, like our friend at the end of the table, are really interested in making sure that their dollars count. And I think that providers are very interested in that too. Parents are very interested in that. The kids probably don't know. So we know that the system we have right now is somewhat flawed because we can only pay in the easiest way to count, which is whether or not someone walks in the door. We are getting better and better at saying what the content of that visit should look like in order to get the outcome that you want. But I still think that the most effort has to be made around articulating what you think that outcome is. So is it that you, and there should be a way to say globally, we want all children to be at grade level. Healthcare has an input into that. They can properly screen children so that they are if there are developmental delays, they can pick it up. If they are missing school because of chronic illness, or if there are modifications that can be made so that a child can attend school, there are ways of articulating the outcome you want from childhood better so that the subsequent measures, the process ones, are more oriented towards the outcome, as opposed to right now, it's mainly utilization. You know, how many, did they show up for their well-child visit? That, we don't even know if that's connected with being at grade level in school, if that makes sense. So I think we have to do a better job of saying what we want, and that way the purchasers can orient their financing and incentives so that everybody gets to do their job with a little bit better support and not feel like they're going against the grain.
I think given that point, I'll turn to Jane first and then to Fred to say just a word about the concept of pay for performance, how far the field really is in making that a reality, or how you feel about that.
How I feel about it.
Yeah, I'm married to a therapist, so I have to ask that.
I'm an objective researcher. Dispassionate, no feelings about these things, Matt. We're actually involved in the national impact study of TIF, which is the Teacher Incentive Fund, which is the federal government's effort to test the effects of pay for performance. Apart from my feelings on it, I mean, I think what our research findings have shown is the way we currently are allocating existing resources to teachers is not being done in a way that is associated with performance outcomes. And that's what is driving a lot of this sort of rethinking of what to do. And I think the thinking is still at relatively early stages, but it certainly is very dynamic and moving very fast. Because if we can't identify a priori who are going to be the most effective teachers, it naturally follows that people will say, well, let's do it after the fact and figure out who are the more effective teachers and pay them in order to keep them in the system. There are debates about the extent to which you want school-level performance rewards so that you generate collegiality and teamwork within the school, and the extent to which you want individual level rewards, given that there's so much variation within school about teacher effectiveness. So it's a question that is really being pushed by the research, and I think we don't yet know what the weak underbelly of it is, or what the real promise of it is, but it's something that's being actively pursued, and it's research that's pushing it.
Good. Fred, in child welfare, how does this issue relate?
Well, I think not too much unlike the healthcare and the education system, we are paying for performance. We're paying too much for what we get. And the challenge is, in terms of breaking the problem down, one is the issue of covered population. Who are you going to pay for? Covered services, what are you going to pay for an eligible person? And then what influence does how you buy? What's the nature of the contractual relationship? Are you paying it prospectively? Are you paying for it retrospectively? And I think in our particular branch of the human services, we haven't done very much with that problem at all. We don't know, for example, in my opening remarks, I pointed out the fact that states vary considerably in the amount of money they pay on a per-child basis. We have no idea whatsoever as to how that variation in investment influences what turns out to be the case. We have no idea then about how the covered population, and both of those are really about the investment questions. Where you feel like you want to cover more children, you have a more expansive safety net. Where you feel you're not wanting to cover so many children, you restrict your investments, and that inevitably will have an effect on the way the outcomes appear. So we have absolutely no concept at all in the U.S. From the federal to the state, from the state to the local. Actually, I think there's more progress being made state to local and local to private agency than there is in the way the nation sees itself in its performance data. But we have no clue whatsoever as to how that variation in covered services influences outcomes. And without any understanding of that, it's going to be very difficult to get to the basic question of monetizing any outcome in the event that we were able to do that without understanding how that variation fits in. I think there's a tremendous amount of frustration in the child welfare system around the fact that there is a very poor alignment on the third point, which is how we pay for services and its relationship to outcomes. They're actually in opposition to one another, where on the outcome side we're trying to reduce time in care, reduce placement stability, or increase placement stability, increase permanency rates. The main funding formula driving the system are pushing the system in exactly the opposite direction. So there does have to be some alignment, but how you tweak that and get the parts of the system, covered population, covered services, and the mechanisms by which you finance that all headed in the right direction towards better outcomes for children, either narrowly defined or globally defined in the construct of child welfare, that is a major bit of engineering that I'm optimistic about our capacity to do it. From a technical perspective, I'm less optimistic about our capacity to do it from a political perspective.
Let me turn to one of the questions that came in prior from one of our web listeners, and I'll turn to Jim first on this because I think it relates to a different view of that nesting issue that he mentioned, of how to think about how a child's doing within an organization related to a family, related to a neighborhood context. The question is, how do you take into consideration that the care of children is a fluid movement between many agencies, making it difficult to attribute positive or negative outcomes to only one program or agency? So as well as that nesting, you have this transition over time that kids move between and among health, education, and human services systems.
Markovian chains, I think, is the answer to the question. It's probably moving from one state to another. But I think there's sort of two principles in statistics that probably apply to how you go about answering that question. One of them is longitudinal, which is you are looking at how a child moves from, or anybody, if you're looking at something that's complex, where there's motion, how they move from one place to another, where there might be different influences or different institutions that they're part of. The other, I think the answer tends to be sample size in a way, because you're looking for people, you're looking to essentially be able to disaggregate statistically enough different combinations of states that you find a person in that you could make comparisons across them. But I think that's extremely difficult kind of problem. And just going to your earlier question, one of the aspects of how you pay for performance, or could or can in different fields, is the production function essentially, and that involves understanding the various inputs that go into some kind of an outcome, so that you can qualify the performance of different providers based on the difficulty of the task that they had. And that involves disentangling, what those various kinds of influences are, and statistically use different kinds of interaction variables and such to do that, which relies on having enough data that you can do it.
And in some of these areas, I think probably child welfare is the extreme. A lot of providers serve very few children, so you have a lot of variation and error that you're dealing with. So even with that kind of comprehensive data you're talking about, you may still only have a handful of kids who experienced that service from that agency. So how you judge the performance of that service or that agency becomes very hard. Let me turn to a slightly different issue, which is how to use this type of thing better. The question is, how could outcome measurement across systems, again thinking not just within one system, increase collaboration in planning or help policymakers do a better job of thinking about the whole child? Does any of the panel have an example where some of that cross-system outcome analysis or performance measurement might have done that, or a vision for what that might look like?
That sounds like Sweden. I think they're doing that in Sweden.
I think it's emerging. I think it's emerging slowly. Elena's comment about looking at the kids with asthma.
We're not in charge of this, so.
So if the healthcare system could tell me or tell somebody, give an indicator.
Here, why don't you use my mic?
Okay. If the healthcare system could indicate for us with some sort of ID which kids had asthma, it would be very simple for us to integrate that in as an outcome variable. And I know that these data systems that are emerging across states, on various panels and advisory boards on them, and they are growing. And there are plans and hopes for integrating in welfare data and integrating in data from Justice Department. So it's possible. Now, at the same time, it's a little bit scary. The privacy police are there, and with worries for some good reasons too. So
this is a huge issue in the child welfare system, where I think we generally acknowledge that historically, although we've called it the child welfare system, it's really been a child protection system. And there is increasing interest in expanding the notion of child welfare broader than the child protection system, looking at educational outcomes. And I think the practice challenges are many, and I think particularly provocative with respect to the human capital requirements of the people who are working in these systems to think across systems, to think globally at the same time that they have to deal with the particular task that they've been charged with embedded within their own particular system. So getting child welfare agencies at the line level, supervisory level, and at the management level to think globally and develop the culture of collaboration is an enormous practice challenge. Think to the issue that Jim was raising about the complexity of the analytic challenge, and Jane was alluding to it as well. Getting folks who are not necessarily even interested in the technology of analysis and what have you, they're interested in using the facts. The facts as they will present themselves in a practice context are going to be just as complicated. So a worker trying to figure out how to insert themselves into the process of that child or that family's life so that he or she can have a positive influence on the developmental trajectory does in fact take a tremendous amount of collaboration, and that's a skill set that in our siloed world where performance, the question will be, does performance, how do we get performance, our interest in performance, to take us away from creating silos, because managing drives you to a point where this is very much a global enterprise. And I think that there's an inherent tension around that very sort of set of of facts and the way these systems operate. So moving away from silos, treating the child as a whole child, but performance measurement oftentimes requires sort of a point estimate. It says, here's how you're doing on reading scores. And that will be a test of our ability and willingness to collaborate at the end of the day.
Good. Let me open it up to the audience here in the room then. If you have a question. Oh, sure.
Just one quick point of contrast before we go on, and it was something that Elena said that struck me with this. While education is very good in terms of right now, in terms of measuring outcomes, at least those outcomes that we have very little understanding of treatment. You know, what should be going on within the classroom, where it sounds like medicine knows a lot about treatment, and that's what it keeps track of, even if it has weaker measures of various outcomes. Yeah. So I think there's a very interesting contrast here between the two.
And child welfare?
But the medical, if the federal government has its way over the next, I don't know how many years it's going to take, but if it does, isn't the medical world going to have the most completely integrated system across providers of anything that we've been talking about, in terms of being able to have those case notes and you grab your cell phone and you can get your entire case history right there instantly, kind of thing, or the physician?
You're talking about electronic medical records?
Absolutely.
Yeah, I think that's an adult, moving through the adult healthcare system. I think the thing about kids is that they're dependent and they move within healthcare, education, and their family and neighborhood. And traditional healthcare on the adult model doesn't really care about education and whether or not these other realms. So when you think about trying to integrate a payment system across an individual silo, that already has some problems. So one of the things I was thinking about when you were talking was, in the adult side, they're trying to create payment systems so that folks don't get paid unless the adult outcome, let's give an example of screening for colon cancer. If the person is screened properly and then is treated, then everybody gets paid. But if that person doesn't go all the way through the system, and the specialist and the primary care physician and the surgeon and the post-hospitalization people don't do their jobs, then they can't get that end payment. And when I'm thinking about kids moving through the system like that, it's not just within healthcare, it's across the silos. So you have to think of reimbursement that unites it. And even before reimbursements, I have to wonder about the structures. We have the structures for children in individual different silos. That's not how other countries do it. Sometimes they just put everything related to children in the same bucket, so it's easier to do this kind of cross-disciplinary work. So that's kind of, I'm even wondering about the structure of our whole child-oriented system, our child system. It's not child-oriented, but
yeah, having had some experience with electronic case records in a more primitive form than the current administration, I assume, imagines that, I think there are electronic records and there are electronic records. And you could easily oversell and underperform on the issue of what does that electronic record look like and how useful is it, not just as a way to store the information, but to provide the information clinicians, family members, other providers from other systems, the information they need to have the acuity required to make the right decision at a particular moment in the clinical life of a child or a family, what have you. And that's a very different enterprise than just gathering up a bunch of case records or medical files and making images of them and storing them on a computer as opposed to on paper. The latter is also an electronic case record. It's stored digitally, but that's a far cry from the kind of information system that delivers knowledge about the particular family in a manner that supports decision making. That requires a theory of organizing the information, and there's a lot of work to be done on that before, certainly in the child welfare business, but I suspect also on the healthcare system as to sort of how to have the right piece of information at the right time.
And at the right time for the performance measurer
Right.
to aggregate it in some form to say
Right.
this unit or person performed adequately. So we have a couple of roving mics. If you could raise your hand if you have a question. I'd like you to state your name and organizational affiliation, and then if the question is for the entire panel or anyone on the panel, say that, or if it's for a particular panelist, please say that. So raise your hand. We have one here in front, Claire.
Hi, good morning. I congratulate all the panel for the information. My name is Esther Chamarela. I'm the director of the Chicago Hispanic Health Coalition. So I will address the issue that working in underserved communities, we're facing a lot of problems. And probably to use a public health model, I think we need to have more an ecological model. And I want to address the school issue with the asthma things. I mean, here we work hard in asthma, how to deal with school asthma care, and sometimes there are problem policy, how to use the inhaler, not to use the inhaler. The other issue is related to CHIP. All kids here in Illinois, we don't know the measure, how much is the outcome related. And confronting a school teacher has multiple problems related to be a social worker. So and going back to longitudinal study, I see that we need to create models who are more comprehensive, less silos, have the measures that we need to deal with in communities that are underserved. So it's just to address, to move from silos to be more global, but they need to be more collaboration to different areas. So healthcare, diabetes, obesity, definitely is an issue. So.
Alina or Jane, talk about ways that you've seen even limited data from the other field come into thinking about performance measurement? Or does the Florida system, for example, which you noted as a comprehensive one, integrate in any way immunization records or any health data that could be useful?
You know, I haven't tried to do that, and this database is so huge. So I'm not completely clear on that. Certainly, to be enrolled in school, you have to be immunized. There are various indicators of whether a child needs special education, although you know the descriptors may not be the ones that are most helpful. So you know children who have extreme issues, you know, deaf, blind, I mean those things are very clear. But under the heading of learning disability, there's lots of things that go in there. So I think we don't do it well, but I think we will. I mean, I think we're on a trajectory here, and we all should be pushing for it.
Alina, how do health performance indicators ever take account of education or
Right.
other
So
issues?
there are, okay, so you can't get billed as a provider or you can't get paid as a provider. There's no way to check off a box that says, okay, the kid I cared for, I did everything I need to do to make sure that they go to kindergarten on time. But within the field of pediatrics, people are articulating things like ready to read. So sort of breaking down more functional things that you want out of childhood. Again, sort of more oriented around cognitive outcomes as opposed to social emotional development, which I think is also making a lot of progress, but just not been integrated as much. So people are working on measures of child outcomes, healthcare quality, health-related quality of life, very disease-oriented as opposed to function, like can walk to school, can sit in a classroom, can take instruction. They just don't show up in billing records. So it's really hard for the healthcare system to orient its payment around it. But as providers, we think about it and we are working on measures. And absolutely functioning in school and going to school is one of the top priorities for any pediatric provider.
it seems to me there's a distinction. The first step is getting someone in one system to think about the things that matter in the other system and to note them. So are educators putting into their own data something about health? Or is the pediatrician thinking about the education needs of the child? A second step is to have the system on the other side share that information or integrate it in some way so that you hope it would be possibly more precise or more comprehensive than it can be when one system's reaching out to the other.
Yeah, I'm looking at Cheryl and Smithgall from Chapin Hall and Bob Gerg in the background, and we have had some luck looking at education data and how children progress through school during the time they're in the child welfare system, either as the subject of a maltreatment investigation or actually placed out of home. And it's illustrative for a number of reasons, not the least of which is it gets you to focus on what's the developmental status of the child at the time they enter into the foster care system. They're not in the foster care system for their entire childhood. In fact, there are very few children who grow up in the foster care system, relatively speaking. It's from birth to age 18. That's a very small number. So in terms of assessing the relative impact of the foster care system on child development, it matters when they start relative to school, for example, how long they're there. In other words, what's the overlap between the school experience and the child welfare experience. And it gives you an idea of the complexity, but also the importance of being able to link the data in that way, because you learn that one of the reasons why children in schools who have been in the child welfare system aren't doing as well is because they started behind. And that is not necessarily a child welfare system issue. That's a host of other contributory factors. Then the question becomes, how does the child welfare system produce gains while there's a joint or mutual responsibility for the child? So that it's interesting as I listen to healthcare looking out beyond and education systems looking out beyond, because the child welfare system does have this sort of latent interest in well-being, that we've had a chance to explore the opportunity to link data in ways that maybe are still forthcoming in some of the other areas.
Good. Other questions? Here in the front also, Mark?
I have two questions. My name is Sarah Karp. I'm with Catalyst Magazine here in Chicago. One of them is they both have to do with the education system, and one of them is whether most of these data systems are using something like Social Security numbers that could be used like in education or child welfare, or if they're using some other state identifier. The second one is whether you had said that in teachers it's not master's degrees or certification or longevity, but does principals seem to have an effect? Because we've always heard that principals are a very important part of whether schools do well and teachers do well and kids do well.
Yeah, okay. First, the Social Security question, and this is something that I've actually discussed a lot with various states as they've been developing their systems. As a researcher, I would never see a Social Security number. States develop their own unique student identifier. But most, if not all now, and I hope they're all doing it, keep in their safe somewhere a crosswalk between that unique student identifier that's used in the school system and Social Security number, because that's what allows us or researchers to link across these silos into the employment realm, for example. So the Social Security numbers are not flying around the country with these data systems. As these data systems are turned over to researchers, they're sort of scrubbed and a different ID is there. Principals. We've actually been talking to a couple of foundations about this. We're trying to do some work on principal effects now with some of the data systems that we're working with. It's a tough analytic problem. Certainly when you talk to teachers, and I happen to be someone who really believes teachers when they tell me something because they usually shoot straight. claim that principals make a whole lot of difference. And when you go out and do qualitative studies, everyone says that. When we try to pick it up empirically, it's a little bit tougher. For example, when we're doing an analysis where we take into account all the characteristics of the kids and then all the characteristics of the teacher, and then add on top of that school characteristics, these school fixed effects, so everything that's associated with that particular school, we don't get a whole lot of more explanatory power. So we're trying to figure out different ways of doing this, with these big longitudinal data systems, where one thing we're thinking about doing right now is watch principals as they change schools. So if there's something about an individual principal that can sprinkle magic dust over school, we should be able to see that effect as the principals change schools. As you can imagine, the requirements of a data system to be able to do that you have to have many years of data and many data points for individual principals. So it's a tough analytic problem. Everyone agrees principals make a difference. We haven't been able to cull that out empirically yet, but we're working on it.
Alina, is there more you could say about this problem of the sort of individual provider in healthcare, or the teacher, and then again the nesting of that person within some organizational setting, and the problem of performance of that individual versus the organization versus the system at a bigger level?
I can tell you that there is a debate about it. And when Jane was talking about it, I immediately, same issue in healthcare. So the idea is whether or not a child is taken care of by a single doctor for long enough that you can actually measure. And certainly a doctor is not spending nearly as much time with a child as a teacher. A teacher spends a full year, maybe 6 hours a day with a child. I'm sure there are a lot of parents in the room who are like, wow, that was a 15-minute visit with my provider. And it happens a lot when you're little, but then it only happens once a year. And there's a problem, so there's a problem with frequency. Then many people think that it's not an individual, what an individual doctor can do with a child is very different from what a system or an entire practice can do for a child. A lot of practices are very small. They only have a small 1 or 2 providers in total. And the general feeling is that the bigger ones are able to build better systems for their offices so they can take on interventions like quality improvement interventions, maintain a registry, be able to do patient outreach, all these extra things that a system can deliver probably a little bit better than an individual provider. So I think it's a debate, but the general tendency in medicine has been that it's hard to ascribe anything to an individual. It's probably better to do it to a practice, at the practice level. And then there's data measurement problems. The more you try and tie kids to an individual provider, the more you run into a small numbers problem anyway, so that even if you thought it happened there, you'd have a hard time measuring it.
This goes back to some of the endogeneity issues too that Jim mentioned, that what providers you have access to, or what school or principal you have access to, is driven by a lot of factors that are hard to take account of. Anyone in the back of the room with a question? Okay, how about here in the middle of the room?
Hi, my name is Selena Chapman-Nelson from Erickson Institute. My question is for anyone on the panel. So I'm thinking about community school models where education, health, and social services are being provided. I wonder if there are any evaluation efforts in those models.
There certainly are evaluations in the literature of the community school model. I guess I would say, and Jane can jump in, I think part of the problem is defining what a community school is or what the model is that's being evaluated. There's a lot of variation in the way when we do integrate, that those integrations happen, so it's very hard then to take from that evaluation aha moment that this is the way we should do it and we should do more of this or that, though I think the current Secretary of Education is interested in expanding that model. Whether performance measured in some way changes because of that integration, I think is a tough challenge, and what we're measuring performance of the school on. So how would you expect a school clinic to change reading scores? Well, you gotta have a logic model of how that might happen and really dig in and understand that. But do you want to add to that, Jane?
No, I think you captured it pretty well. And not only would you run into issues of variation across models, but you also need to have those models stable for a number of years in order to capture any change over time that they might create. But I think they certainly are promising, and there is an association of community school, and there's probably more research than I know about in this area, to be honest.
You're raising an issue, I think, about certainly the point of the panel is, and I'm sure most of the audience agrees, we need to start thinking across systems more. So co-location is one way to do that. Actually put the health clinic there, bring the social services in, move the school out. But whether that, again, performs better than other forms of integration is a real challenge.
Yeah, I was just going to wonder what the performance is, because there's certainly, if you remove it from a communities and schools model, just simply the question of co-location, there's one way of thinking about it is that these things somehow work in synergy, and you get a better outcome from each because they're neighbors or related. But I think a lot of the purpose has been simply to recruit patients or clients. By co-locating, you simply make the logistics easier. You essentially advertise better. And it's not that the performance is any better. It's simply that you reach people who wouldn't have been otherwise reached. Mm-hmm. So I think we probably want to think about what the goals of the model are.
Here in front, Claire.
Good morning. My name is David Child, and I'm with David Child. You talked about the co-location problem and maybe moving the schools out. Might I suggest that we consider the opposite? Cynthia Parsons, back in the 1980s, in her book Seeds, suggests that the school be utilized longer during the day, that social agencies and health agencies and police agencies and parent agencies be located at the school. Ted Aoki from Alberta, Canada, talked about his school, which had that kind of thing, that parents were brought in during the day, there were programs for them. And also something that Jim had said, that people in schools and welfare are probably not at risk for death, but doesn't seem to be the case in Chicago.
I actually said moving the schools out, thinking maybe there are models like that. Most of the community school models are attempts to move these things into the schools in some form, whether that's better connections or literally putting a health clinic in a school or a social service agency in a school, providing out-of-school time. But Jane, I don't know if, Jane, is there really a soundbite finding of the performance value of any of the models of, I think it's a very complicated question that, again, because there's so many different ways of doing it and so many different outcomes we care about.
Yeah. I don't think there is a clear bottom line soundbite with good research. There certainly is some face validity to the case, making a case for it that I think we all would agree with. The only thing I was thinking of as this discussion was going on is KIPP academies, which is probably the most successful among the charter school providers, who do, as a very conscious part of their model, involve parents heavily in the system with contracts and understandings between what goes on at home and what goes on in the school. They do have very much extended day and extended week in order that they are more able to capture the whole child and deal with the development of the whole child. And it's been, I think, among the more successful charter school efforts. So again, there's face validity, there's some evidence out there, but I can't think of any, large systematic effort that's been able to try to capture effects generally. But again, I could be ignorant.
Yeah, certainly certain models have been evaluated, and some of those look successful. But as far as how to use that in that form of integration to drive performance across systems, I think you then get to Jim's question of compared to what? What are some other models to do that? What's the relative value of investing in that form of model versus others?
Let me just add, I think the question, while focused specifically on schools, but when you started talking about all of the things that would be integrated in the context of school or the education system, I think it raises cultural questions, that the extent to which that is viewed by the people in a local community as a desirable place to locate that integration may vary from place to place. Families within those communities may respond, and it alters the dynamics of residential choice. And so I think that's a particular challenge. We as researchers, I suspect that if we had a long and detailed conversation about what we mean by outcomes, we haven't really gotten into that question too deeply right now. And so that's convenient, because then you can have a conversation in a short amount of time without getting into some of the more pernicious problems. But I think at the end of the day, the forms of integration are going to be to some extent culturally bound. We really haven't talked about the particular problem that poses in this country, as opposed to Alberta, Canada is Alberta, Canada. That's a different context than you would find in parts of Illinois, parts of Chicago, or other parts of the United States. And so this is ultimately a cultural and a political problem in terms of how these things come together, even though we all understand that treating the whole child is the right way to do it. The meaning of that on the ground is going to be highly differentiated by who you are and what your traditions are.
Thank you, Fred. I'm afraid we're actually at the end of our time. I think by nature we knew when we took on this topic this would be in some ways skimming the surface. This is a hugely complicated endeavor. I want to thank our panelists for enlightening us in a short amount of time a lot, challenging us to think about where to go with this. These are certainly questions that we've not yet answered within a field or across fields. We have a lot of work ahead of us, but also a lot of new and exciting things to look forward as data systems develop, methods develop, and concepts develop. So I'd like to thank the panelists. I'd like to thank Carolyn and Claire and Mark, the Chapin Hall communications staff, for putting this together. Thank the Urban Institute for co-hosting Thursday's Child, and thank all of you for spending some time with us today. Have a good day.